Okay, so we'll start with the next topic, which is on antimicrobials in the immunocompromised. So this is a special situation again, which some of us will, I mean, almost all of us will encounter at some point of time during our career. And with the burden of diabetes, I'd say every one of us will have to deal with it some point of time or the other, right? So I'd like to acknowledge Dr. Amita Agarwal, ma'am. She's taken this lecture before, and some of the slides are adapted from her talk before. So learning objectives, we'll learn first who is the immunocompromised host and the types of infections that they're susceptible to, and then we'll move on to specific case scenarios and deal with the complications that may arise. Right. So the screen is divided into two parts. On the left, you can see primary immune deficiencies, and maybe other than hematology and clinical immunology, a lot of you may not be encountering these patients a lot, but these are the group of primary immune deficiencies that may exist. And these are T cell defects, B cell defects, combined immunodeficiencies, phagocyte defects, complement deficiencies, and innate immune defects. Again, a very niche group of patients, but at least when they come to you, you may refer them to the correct specialty, that is immunology or hematology for management. The secondary immunodeficiencies are interesting. These are the ones that most of you will encounter, and diabetes is the primary one there. India is the diabetes capital of the world, and most of you will encounter patients of diabetes throughout your career. Any loss of barrier functions, so any burns or trauma. So all our surgeons might encounter these patients where people are secondarily immunodeficient due to an accident. Malignancies, again, these patients are immunosuppressed. End-stage renal disease, end-stage liver disease, these patients don't have an effective immune system. Immunosuppression, so a lot of specialties here may be using immunosuppression. We use a lot. Hematology uses a lot. Even gastroenterology and nephrology would be using a lot of immunosuppressive drugs. Adverse events of drugs, so a lot of the drugs that we use, and chronic infections like HIV, hepatitis B, and hepatitis C. So what are the organisms that are prone to cause infections in these patients with immune defects? So just in simple terms, cell-mediated immunity means where your lymphocytes are deficient, right? It may be your B lymphocyte population or your T lymphocyte population. But anyone who's having lymphopenia, they have defects in cell-mediated immunity, and they will be prone to infections with viruses. So herpes zoster, the entire herpes group of viruses, CMV, fungi, again, Candida, Cryptococcus, Aspergillus, any fungi really. They may be more prone to intracellular bacteria. So Listeria and Salmonella, these are organisms that we see typically in patients who are deficient in the cell-mediated immunity. They'll be prone to mycobacterial disease. So TB it's rampant in India, and it's the most common type of infection that we see in our immunosuppressed patients. And parasites, so toxoplasma at unusual sites, anywhere in the CNS toxoplasma, you should always suspect some form of immunodeficiency, right? Humoral immunity, this means where your patients are antibody deficient, and a very, very cheap and effective way to look for this is their total globulin fraction. So you have the total protein and albumin levels, you can just subtract the albumin from proteins. And if you have a patient with low total globulins, irrespective of what the immunoglobulin levels may be, this patient might be having some sort of humoral immunodeficiency, right? And these patients can have mainly bacterial infections. So strep pneumonia, you'll see, will be common across all sites. So rhinosinusitis, meningitis, otitis media, lung infections. Strep pneumonia is the most common infection you see here. Other bacterial organisms, all capsulated bacteria, Haemophilus species, Moraxella catarrhalis, even Staph aureus in the lung, bronchiectasis. These patients develop early bronchiectasis early on in life. You can have GI infections with H. pylori, Giardia, Campylobacter species, Salmonella species, and Cryptosporidium. And you may have sepsis via pyogenic encapsulated bacteria, right? Mycoplasma arthritis, that's a very typical organism that you see with patients with humoral immunodeficiency. If this grows on culture, by default, the patient has an immunodeficiency that is yet to be proven. And skin abscesses, so skin abscesses that are disseminated and do not have the typical signs of inflammation, those almost like presenting like cold abscesses, you should always be aware of possible immunodeficiency in these patients. So principles of management, the first principle as always is prevention, prevention, and prevention. If you can prevent an infection in these patients, nothing like it. But if you fail to prevent, an early diagnosis and treatment, where you can start effective empirical therapy based on a high index of suspicion, and the the basic principle of escalating and de-escalating as per the culture report, it stands true here as well. The caveats here are that your serological tests may not be as effective, right? So even in the diagnostic criteria for a lot of these humoral immune defects, your serological test, failure of serological tests is part of the diagnostic criteria there. So patients who are not turning up to be IgM or IgG positive after a known or documented infection, that is a definite sign of immunodeficiency. So you cannot rely on your serological tests. You should rely as far as possible on PCR and cultures. So on the first step, what's most important is hand hygiene. We had a lecture on the first day itself on hand hygiene. And this doesn't involve hand hygiene only on the part of the doctor or the nurses. Remember, you're not the one who's most in contact with the patient. The person who's in contact with the patient all the time is the patient's relative. So what we do when we have patients who are immunosuppressed, we keep a chlorhexidine bottle in the room and tell the patient's relatives that whenever they are touching the patient, and this will be when they're giving them food, when they're helping them to the bathroom, they should be washing their hands. So your patient's relatives should be made aware of this fact. The second thing, I mean, this is a pet peeve of mine, bare below the elbow. So our institute paradoxically actually reinforces bad practices here. We get castigated for not wearing aprons. Nowhere in the world are full sleeve aprons mandatory for the hospital. It has been proven conclusively to transmit infection between patients. And bare below the elbow means even your wristwatch is not good for the patient, right? It's a method of transmitting bacteria from patient to patient. If you go to the NHS, you may be the head of department, you may be the director of the institute. If you have anything below your elbows, even a full sleeve shirt or a watch, your nursing coordinator can report you to the hospital as a threat to patient management and patient safety. So at least when you're taking care of your patients, please wear half sleeves, or you can roll up your sleeves, and don't carry around a watch, right? Respiratory hygiene, masks. So this has gotten even more important after COVID. You may not be immunosuppressed. You may not have severe COVID. You're vaccinated, but your patient who's immunosuppressed may not have the same benefits as you. Even though immunized, they may get a bad infection and die. So I mean, just last week we had a patient in our ward who was getting well with fungal pyelonephritis, suddenly deteriorated and died. And when she got intubated, we took a swab and she had COVID. So you're doing this for your patients, not for yourself, right? And good nursing care goes without saying. So barrier nursing, nurses should be made aware of hand hygiene protocols and good nursing care in general. Avoid unnecessary catheters. This again goes without saying. Every day in the morning, you should be questioning whether we need this catheter, whether we need this Foley's, whether we need this central venous catheter. And some things that the patient can do at home, right? So boiled and filtered water, avoiding raw foods, avoiding pet contact, vaccines. But the caveat there is not live vaccines, right? A lot of immunodeficient patients can get disseminated infections from live vaccines. Even someone in the family should not be getting live vaccines, especially for primary immunodeficiencies. You know, we tell the patient that your brothers, your sisters, your family members should not be getting any live vaccines because they can get severe life-threatening infections. So what does not help? And again, this is another pet peeve of mine. In any ward and ICU, you go around here in SGPGI, people will run after you with foot covers. Nowhere in the world has foot cover been proven to prevent any sort of infection whatsoever. If anything, you are actually transmitting more infections to your hands while you're putting them on, because God knows where your feet have been, right? So absolutely no benefit. If you can drive it out of the system, kudos, good on you. Special diets. I mean, this is food faddism is the biggest in thing in India right now. Everyone has some sort of food faddism, and I mean, I think everyone has faced the situation of papayas for platelets and whatnot. So none of that works, right? It does not help. So we'll move on to some case scenarios. First up is this 4-year-old boy who's B-cell ALL on induction chemotherapy, and he's presented with fever for 6 hours, right? And on examination, he's clinically stable. There's no localizing sign that you can make out. And his hemoglobin is 6, TLC of 1000, ANC of only 300, and platelets of 26,000. So he's neutropenic and he's having fever. The second patient, this is again very common in the rheumatology ward. We have a patient, a 49-year-old female with inflammatory polyarthritis for 2 years, and she's diagnosed rheumatoid arthritis with RF and anti-CMV positive. And she's been started on methotrexate recently, 15 mg per week. And 2 weeks later, she comes to the OPD with fever, 101 degree Fahrenheit, with oral ulcers for 4 days. And she'll show you the blister pack of methotrexate, and all 12 that were given for 3 months have been consumed in 12 days. So daily she's taken it daily by mistake, and she has now pancytopenia with an absolute neutrophil count of 190. The third patient, this is again very common in the immunology ward, lupus, diagnosed for 2 years with fever, ACLE, and active urinary sediments. And dsDNA is high, C3, C4 is low, 24-hour urine protein is again high at 2.6 grams. And the renal biopsy has shown class 4 lupus nephritis. And she's attained clinical remission post NIH cyclophosphamide for 6 months. And we start the patient on maintenance azathioprine. So 1 week later, the patient presents with fever of 101 degree Fahrenheit, HB of 11, and TLC again of 300 only. So this is a very common scenario. Again, in India, we don't really test for thiopurine methyltransferase mutations because it's not cost effective. It's not a common mutation. But if it's there in the patient, it's an idiosyncratic reaction. There's nothing you can do to prevent it, and there's nothing you can do to treat it. You have to wait till the leukocytes regenerate. The patient produces new leukocytes, and roughly that takes 10 to 15 days, right? So all 3 scenarios had febrile neutropenia. Okay. So what do you do in such patients? So there is this risk score that was developed for cancers. So this is known as the MASK score. So this is a clinical score, very simple, that can be applied to every clinical situation with febrile neutropenia, where you look at the burden of febrile neutropenia. So the number of mild, no or mild symptoms with a weightage of 5, moderate symptoms with a weightage of 3, no hypotension with a weightage of 5, no active COPD with a weightage of 4, solid tumor or no previous fungal infection with a weightage of 4, no rehydration requiring parenteral IV fluids is 3, outpatient status 3, and age less than 60 years is 2. So the higher the score, the less severe the patient's symptoms, the less the burden of febrile neutropenia. And based on this, you can then classify the patient. So patients with febrile neutropenia, that is 38.3 degree centigrade temperature and ANC of less than 500 per microliter, you assess the patient. And if the score is more than 21, MASK score of more than 21, if it's a solid tumor and neutropenia is anticipated to last for less than 7 days, and there's no hemodynamic instability, you can manage this patient in the outpatient department. You can send up the blood cultures and do symptom-directed workup, maybe an X-ray, IV antibiotic, a first dose of IV antibiotic, and you can observe in the clinic for 4 hours, ensure the patient is stable, has good oral intake, and you can follow up within 24 hours in the clinic, right? And you can then stratify whether these patients are on fluoroquinolone prophylaxis. If yes, you can give them outpatient IV antibiotics, that is FFM, because this patient has developed infection on fluoroquinolone. And if they're not on fluoroquinolone prophylaxis, they can be started on a fluoroquinolone, that is ciprofloxacin plus amoxicillin clavulanate, or levofloxacin or moxifloxacin. So those who are at high risk, so a MASK score that is low here, less than 21, or if this is a hematological malignancy, or the patient is on chemotherapy, or has had a transplant, and if the anticipated neutropenia is more than 7 days, you have to manage this patient as an inpatient, right? You have to send off blood cultures, you have to do a symptom-directed workup again, and daily clinical and laboratory assessment is necessary. And you start off on antibiotics, IV antibiotics straight away. So cefepime, piperacillin, tazobactam, meropenem, if history of ESBL exposure is there. All of these are very rational, right? So 72 hours after initiating empiric antibiotic therapy, you do another risk assessment. And if it's low risk here, you then look for ongoing fevers. If the patient is having ongoing fevers, you hospitalize definitely, and you consider imaging, again X-ray, CT if it's indicated, and you repeat the blood cultures. And if positive cultures, you treat accordingly. And if the patient is low risk with no fevers, you can just review the cultures that you have sent already. If there's a documented infection, you de-escalate antibiotics to the culture that is positive. And if there's no documented infection, you continue empirical antibiotics until the ANC reaches more than 500. Or you can consider stopping if ANC recovery is imminent and the patient is clinically stable. So this is for your low risk patients that you are managing in the outpatient. So your patients who are high risk, and if they have ongoing fevers, you have to continue empirical antibiotic therapy. And this is common sense, right? You have to give them IV antibiotics. And you consider imaging again a CT if it is indicated, infectious disease consult if it's available. And if there's a documented infection on the cultures, you again change antibiotic therapy accordingly. If no, you can discontinue vancomycin, maybe add an antifungal. And if the patient does not have any fevers ongoing, you can then look for again cultures for any documented infection and de-escalate accordingly. Otherwise, continuing antibiotic therapy is same as for the low risk patients. When neutropenia is resolved, or if the patient is stable and the neutropenia is imminently resolving, right? So how long do you continue empirical antibiotics? There was this clinical trial reported in 2017. Appropriately, this is named the How Long study, and the primary outcome here was empiric antibiotic-free days. And what they wanted to see was in febrile neutropenia patients, can you risk stratify them based on clinical features alone? So without going by the ANC, absolute neutrophil count. So the experimental group, antibiotics were stopped if there was no fever, there were no signs or symptoms of infection, and there was no normal vital signs for at least 3 days. Whereas in the control group, this is standard of care, what's practiced generally. You waited for the ANC to go above 500. You waited for no fever or signs or symptoms of infection and normal vital signs for at least 3 days. So randomization was 1:1. And what did they see? So definitely neutropenia, persistent neutropenia at the time of withdrawal of empiric antibiotic therapy was higher in the experimental group, 53% versus only 10.1% in the control group. But did it really affect outcomes? And that is the important question here. So if you look at the intention to treat analysis, the antibiotic-free days was way higher in the experimental group, significantly higher in the experimental group. And the crude mortality actually didn't differ. So whether your neutrophil count has gone back to 500 or not really didn't matter. What mattered was whether your patient was clinically stable or not. And the same things was repeated in the per protocol population. So the next case is a 25-year-old male who has fatigue for 2 months, epistaxis for a week, and he has pancytopenia on the hemogram, and the bone marrow is showing an acute myeloid leukemia, and you're planning to start this patient on induction chemotherapy. So would you like to give this patient prophylactic antibiotics? So yes, so when the patient is supposed to get a therapy that will result in neutropenia, you're anticipating neutropenia due to the therapy itself or the disease itself that is going to be prolonged, you need to give this patient antimicrobial prophylaxis. And these are guidelines from the American Society of Clinical Oncology. So this is there separately for antibacterials, antifungals, and antivirals. For antibacterials, again, patients who are at high risk of febrile neutropenia or protracted neutropenia, you can give them fluoroquinolone prophylaxis, daily fluoroquinolones, and you continue till the period of expected neutropenia, right? For antifungals, again, patients who are at high risk of neutropenia or profound protracted neutropenia, patients with GVHD, or patients who are having chemotherapy regimens that have a high risk of pneumocystis jirovecii pneumonia, right? So these patients, you give prophylaxis again with an antifungal, a triazole or a parenteral echinocandin, caspofungin, something like that. You can give a coverage for aspergillus, something like voriconazole, if there's a risk of more than 6% in patients with AML, MDS, or treatment for GVHD. And again, has to be continued till the period of neutropenia is there. And if the risk of pneumocystis carinii is high, you can give them prophylaxis with trimethoprim sulfamethoxazole. And you can continue till the patient basically recovers from the immunosuppression, right? Antivirals, again, depends on the patient population. So if the patient is HSV seropositive, that is herpes simplex serology positive, you can, and they're undergoing transplant or leukemia induction therapy, you can give them antiviral therapy using prophylaxis using acyclovir. And you give it till the patient recovers their WBC counts or there is resolution of the mucositis, whichever occurs later, right? And patients who are at substantial risk of HBV reactivation or HBV infection, you treat with a HBV directed antiviral, that is tenofovir or entecavir, and you can follow the guidelines of IDSA for treatment of HBV, how long it needs to be done. Any individual who is treated with a chemotherapy for malignancy and has family and household contacts of influenza, you should be administering anti-influenza vaccination for the patient as well as the household contacts. And the vaccination, I mean, the ideal time is, prior to induction of chemotherapy, but this is not always possible. Even we encounter this very often. We have to give it when the patient is there with us, in contact with us. So any vaccination is better than no vaccination, right? So pneumocystis jirovecii pneumonia prophylaxis indicated in patients with lymphoma on high dose steroids, HIV, or those who are undergoing stem cell transplant, CD4 of less than 200 per millimeter cubic millimeters, solid organ transplants or primary immune deficiencies, and I mean, any history of primary previous PJP clinical infection. You can give these patients cotrimoxazole thrice a week, or if they're allergic to sulfur drugs, maybe pentamidine in that by a nebulizer. The patients can also get dapsone, 100 mg daily. So this was a patient population in South India. This is a lupus cohort from Christian Medical College, Vellore, and they looked at how antimicrobial prophylaxis to PJP and in general TMP SMX, how it acts as an antimicrobial prophylaxis, and they found that those who had cotrimoxazole prophylaxis had a significantly lower incidence density of major infections. So incidence density of around 1 per 100% year follow-up in those who had cotrimoxazole, compared to around 12 for those who did not have prophylaxis. And this was a patient population in which the steroid dose was more than 0.5 mg per kg. So that's not a very high dose. So for Indian patients, that's practically 20 mg of prednisolone. So anyone more than 20 mg of prednisolone, you may be effectively reducing the rate of infections by around 10 per 100% year. So antifungal prophylaxis, again indicated for anyone who's undergoing stem cell transplant or AML or ALL induction. For candida, you can give coverage with azoles, fluconazole, itraconazole, or voriconazole, even posaconazole, micafungin or caspofungin, if the patient can take outpatient IV prophylaxis. But the caveat here is that low dose oral fluconazole, 50 to 100 milligrams, does not provide antifungal prophylaxis. It may result in selection of antifungal resistant strains, right? And invasive aspergillus, again, posaconazole can be given as prophylaxis for these patients. So for oral candidiasis, you really can give just short courses of appropriate therapy. Fluconazole, most of our oral candidiasis is responsive to fluconazole. So anti-CMV prophylaxis, this is another very devastating organism that can develop post-transplant especially. So this is a cohort of patients of liver transplant. 205 patients, they were randomized to preemptive treatment of CMV based on the CMV viremia, or they were given CMV prophylaxis with valganciclovir irrespective of the viremia. And as you can see, those who had antiviral prophylaxis with valganciclovir in the initial 100 days, they had a significantly higher disease burden compared to preemptive therapy. There is actually no consensus on what to do in this situation. Most centers, you will see that patients do end up getting antiviral prophylaxis throughout their post-transplant course. But this was one study that showed that even if you just detect viremia and treat it preemptively at the time of detection of viremia, your cumulative burden of CMV disease does not actually change much. So post-renal transplant, again, the CMV reactivation rates are quite high. So 8% in those who are donor positive but recipient negative in patients with renal transplantation, and 4% in those who are donor positive and recipient negative in patients with liver transplantation. Prophylaxis that is recommended is generally oral vanciclovir for at least 100 days, and a lower level of recommendation is therefore IV ganciclovir for 28 days. So what happens to other organisms that these patients are prone to when you give them prophylaxis with valganciclovir or ganciclovir? So this is a renal transplant cohort in which they have seen all patients who have had valganciclovir prophylaxis for CMV. And then they've looked at their CMV viremia, CMV infection, as well as BK viremia, BK virus viremia, and a clinically relevant polyomavirus nephropathy. And as you can see that the rates of clinical infection with BK virus and CMV are similar. They're quite low when these patients are on anti-CMV prophylaxis. Whereas CMV viremia and BK viremia develop in a much higher proportion of patients. So just goes to show that you should not be maybe chasing after the viremia. but giving prophylaxis to all patients to prevent clinical infection in patients with renal transplant. Because here the graft rejection and the graft function depends on the BK virus reactivation. So it's something that you cannot be so lackadaisical about, basically. So you have to give vanzacloprid prophylaxis here. So this is a table that we have all been mugging up since our, I think, post MBBS MCQ days. So how are patients susceptible to infections? So time-wise, less than 1 month. Patients are susceptible to hospital-acquired infections, MRSA, vancomycin-resistant enterococcus, Candida species, catheter-acquired infections, aspiration pneumonia, wound infections, anastomotic leaks and ischemia. They're susceptible to Clostridium difficile, and they're also susceptible to donor-derived infections, right? HSV and CMV, West Nile virus, HIV, Trypanosoma cruzi, and fungal infections. So fungal infections that are mainly colonizers, so aspergillus, and some bacterial infections like Pseudomonas. 1 to 6 months, PCP prophylaxis becomes important. Antiviral prophylaxis to CMV and hepatitis B. Polyomavirus, BK virus infection, which we just saw. Again, these patients are prone to C. difficile colitis because of increased contact with the hospital. Hepatitis C reactivation occurs at this time. Adenovirus infection, Cryptococcus neoformans, Mycobacterium tuberculosis. It's ubiquitous in India. And other infections like pneumocystis, herpes viruses, hepatitis B reactivation, and atypical bacterial infections like Listeria and Nocardia. And more than 6 months, these patients are now resembling normal patients. So community-acquired pneumonias and UTIs become important. Infections with various fungi, molds and mucors, and infections with nocardia and other atypical bacteria like rhodococcus. This is in patients who are on therapy like sirolimus or mycophenolate that is causing profound cell-mediated immunosuppression. And you can have some patients with late viral infections. Any patient who's on immunosuppressive therapy, especially mycophenolate or sirolimus, which is depleting the T cells, you can always have CMV reactivation at any point of time. Right? The next case is a 22-year-old male who has fever for 6 months, abdominal pain for the last 2 months, weight loss of 10 kgs in the last 2 months, gangrene of the toes for a week, and he has a high CRP. His ANA and ANCA is negative, cryoglobulins is negative, and the renal angiograms is showing microaneurysms in renal arteries bilaterally. So a textbook case of classical PAN, I think everyone will agree. And this patient is hepatitis B positive, HBsAg surface antigen is positive, HBV DNA is not detectable, and IgM anti-HBC is negative, while IgG anti-HBC is positive. So this is a patient who has had an infection previously and has successfully cleared the infection. So he doesn't have infection currently. So what should be the next line of treatment? So would you give this patient immunosuppression alone for the classical PAN that he has? Would you give immunosuppression with tenofovir? Would you give him tenofovir alone and hope that the PAN goes away with the treatment of hepatitis B? Or would you give the patient immunosuppression with serial HBV titer monitoring? So you have to volunteer. Anyone can volunteer? Okay, so for A, how many for A? No one for A. So for B, immunosuppression with tenofovir. Okay, if you have 1 person. Okay, 2 persons. Yeah, at least the immunology resident, I think. So tenofovir alone. Or someone would like to monitor, just immunosuppression monitor. Yeah, so in this case, you actually have to treat simultaneously. You can't leave the patient's polyarteritis nodosa up in the air. It's a disease that kills, but you have to give tenofovir even though the infection has been cleared, because this patient will be immunosuppressed subsequently and he'll have reactivation of the virus. So this is a 12-year-old girl with SLE, fever, acute cutaneous lupus, NPSLE, and nephritis. Renal biopsy is class 4 nephritis. She's been given IV methylprednisolone pulses for 3 days, followed by 0.5 mg per kg prednisolone. And she's gotten an NIH cyclophosphamide again. And she comes for the second dose of cyclophosphamide at day 28. And she has history of low-grade fever for 4 days. No localizing signs. She's hemodynamically stable. The nadir TLC. So this is something that we check for effective use of cyclophosphamide, whether cyclophosphamide has been effective. At day 14, the nadir TLC was 2200, which means that the dose of cyclophosphamide was effective. And the present TLC is 28,000 per cubic millimeters, right? Neutrophils of 88% and lymphocytes of 8%. So what would you do for this patient? So options are: would you start empiric antibiotic therapy, reduce the immunosuppression? B, would you admit for evaluation of infection? C, would you intensify immunosuppression after ruling out infection? And D, would you continue same regimen of immunosuppression? Okay, so any other takers? So this is a patient who's responded to cyclophosphamide. This is a very common scenario that we see. So whenever you have a pediatric patient who has leukocytosis on steroids, don't jump the gun and think of infection primarily. This is a normal response to steroids. 28,000 TLC in a young child who's on 0.5 mg per kg prednisolone. It's fairly normal. That's the response that you expect. There's neutrophilic leukocytosis and lymphopenia. This is what you'd expect. This patient has had a good response to cyclophosphamide, and her initial manifestation was fever. So this was an actual patient of ours who had fever as the initial manifestation. And these patients generally, when the disease relapses, they come with the same manifestation again and again. So fever in this case was actually a manifestation of disease activity in this patient. We also went wrong with this patient. We actually started empiric antibiotic therapy and sent the patient home. And this patient landed up again 2 weeks later with a severe flare of disease. She came back with seizures with a frank neuropsychiatric flare. And we had to ultimately intensify her immunosuppression after ruling out an infection. So don't be afraid of leukocytosis without any clinical signs of infection if the patient is on steroids. It's a normal response of the body to the steroids. So the last scenario, this is a 63-year-old male patient with seropositive RA from 2005. Erosive disease on optimized triple therapy. And he's developed atlantoaxial dislocation requiring C1-C2 fixation. And he's been referred to immunology now for disease control. Right? He's been initiated on rituximab induction, 2 doses. And after the first dose itself, he is presented with polyuria and lower abdominal discomfort, no fever, and the urine routine is showing 10 to 15 pus cells. So what would you do in this scenario? Any takers again, other than Kishan? Kishan probably knows this patient. So would you admit for evaluation of possible sepsis? Would you treat with oral antibiotics and observe? Would you give the second dose of rituximab as scheduled? Or would you send a urine culture and wait for the results before further decision? Okay. Anyone else for any other option? Yeah, so you would admit this patient for possible sepsis. So let's go back to the scenario. This is a patient who has had severe lymphodepletion, right? Rituximab. 500 mg of rituximab is enough to wipe out your entire lymphocyte population. So in this patient, even with someone with such vague symptoms, with polyuria, lower abdominal discomfort, the patient may not have fever. Most of these patients who are severely immunosuppressed, they do not have fever as a manifestation of sepsis. So your antenna needs to be up. You need to be very vigilant. And in fact, this patient had pyelonephritis. This is a patient who was there in our ward just now. Frank pyelonephritis, bilateral kidneys were enlarged. The urine culture grew E. coli, even though he had no fever at onset. And he had AKI as a result, had to undergo dialysis. So this is a situation where lymphodepletion has occurred, not just with rituximab, with cyclophosphamide, any lymphodepleting agent that has been given as induction. You need to be aware of such vague symptoms. And don't go by the fever. Okay, so this is the last case. So a 26-year-old male who's under treatment for acute leukemia develops fever with hypotension and poor renal output over 4 hours, which is the most likely infectious agent. Yeah, so gram-negative bacteria, right? E. coli. So gram-positive sepsis in the setting of any immunosuppression is rarer as compared to gram-negative sepsis. So E. coli here is the answer. So take-home messages. First and foremost, recognize the immunocompromised patient. If you don't succeed at that step, you'll never pick up an infection, right? So remember that list of immunosuppressed patients that you're likely to encounter. Prevent infections as far as possible. Hand hygiene, antimicrobial prophylaxis where indicated. Maintain a high index of suspicion for infections and a low threshold for admissions when they're immunosuppressed. Empiric antibiotics that are broad spectrum, all the while being directed to the most likely origin of infection, and de-escalate once cultures are available. So common sense things, right? These are all common sense things. Thank you. That's all.